Hello and welcome to the 2020 Wood Forum on Hip Health. On behalf of the University of Calgary and the McCaig Institute for Bone and Joint Health, welcome to the 2020 Forum on Hip Health. I'd also like to take this opportunity to recognize and acknowledge the traditional territories, the people of the Treaty 7 region of Southern Alberta, which includes the Blackfoot Confederacy, comprising of the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and Stoney Nakoda, as well as the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. Although this year's Woods Forum looks a little bit different, actually this is the first time I've put on a tie in a while, I'm happy to still have this opportunity to gather online and welcome a wider audience from across Alberta and beyond. Thank you all for joining us today. It's going to be a great event. To introduce myself a little bit, my name is Jon Cornish. I have a history of bone and joint problems myself due to a long career playing football. I played about 20 years of football, but actually, of the hip injuries I've had, most of them have actually occurred off of the football field, which I'll look forward to digging into a little bit. I'm definitely very keen on hearing all of our presenters today, and I'm sure we'll all come away with something that will be able to help us in our ongoing lives. So just a few housekeeping items. Today's event will host 4 presentations from our expert speaker panel. After our first 2 presentations, there'll be a brief 3-minute break for everyone to stand, stretch, grab a water before we resume with the remainder of the program. If you have any questions during the presentation, feel free to submit your questions into the Q&A box. When you do that, you'll let us know that you have that question, and we'll be able to touch on those questions at the end of the presentations. After the presentation, there's going to be a 30-minute Q&A with the speaker panel, and our speakers will be happy to answer any general questions, but they are unable to offer specific medical advice. I know this frequently comes up at the Wood Forum. If you have a specific personal issue, that's always best to talk with your doctor about. Lastly, today's presentation is being recorded, and the recording will be shared on YouTube and the McCaig Institute website after the event. So carrying on. Before we start the program today, I would like to welcome Dr. Stephen Boyd, a researcher and director at the McCaig Institute for Bone and Joint Health. Stephen is a professor in the Department of Radiology in the Cummings School of Medicine, with joint appointments in the Schulich School of Engineering and the Faculty of Kinesiology. His research focuses entirely on adaptive changes in the bone that occur after joint injury and disease. But today he's not going to be talking about his own research, which, all over the place. It's pretty cool. But he's going to be talking about the McCaig Institute for Bone and Joint Health. So Stephen?
Great. Thank you very much, Jon. Thanks for the introduction. As Jon said, my name is Steve Boyd. I'm a professor in the Cummings School of Medicine. I see Jon through in my other academic appointments in there as well, which is very nice. I'm also director of the McCaig Institute for Bone and Joint Health. So this year's Wood Forum is on hip health. And ironically, it's a very timely topic for myself. Unfortunately, in September, I had a mountain biking crash and I broke my femoral neck in my right hip. So a pretty serious accident. So I'm particularly interested in issues around hip pain, recovery, and overall hip health. And particularly, did I say recovery? I'm very interested in that. So, but I'm not here to talk about my own injury. I actually want to talk about the McCaig Institute for Bone and Joint Health. So the McCaig Institute for Bone and Joint Health is based at the University of Calgary, and it's a multidisciplinary team of rheumatologists, endocrinologists, orthopedic surgeons. We're going to hear from some of those people today, radiologists, so lots of medical doctors, as well as basic scientists in all sorts of areas related to cell biology, immunology. We have kinesiologists and we have biomedical engineers, which is what I am. So we all work as a team toward improving bone and joint health. Some of the issues we focus on are things like osteoporosis, osteoarthritis, rheumatoid arthritis, and we even look at things like high performance sport and how that can affect hip health across the lifespan. Our vision really as an institute is to lead musculoskeletal health in Alberta and across Canada and internationally. We want to improve research and education in those areas so that we can provide pain-free mobility for everybody. That is within Alberta and beyond. What many people don't realize is at the McCaig Institute, we have some of the national and international leaders in the area of musculoskeletal health who are doing fantastic work, and you're going to hear from some of them today. But a lot of this work couldn't happen without the help of our community support. And in fact, I want you to think as you're watching these presentations about how that is important to us being able to continue this important research. And if you are inclined, please visit our McCaig Institute website. It's mccaig.ucalgary.ca, or you can simply Google it. And if you're interested, donations are more than welcome. There's a button there that you can click at the bottom. So I'm going to just switch my next slide here using a fancy technology. And I'm going to talk about the Wood family. So the Wood Forum is an initiative that has been supported by the Wood Joint Research Fund that was created by Drs. Jon and Christena Wood. And that's now carried on by Dr. Donna Wood in their memory, in their honor. And each year, we host forums related to bone and joint health that bring the public and researchers together to discuss the impact of bone and joint health on disease and improving mobility across the lifespan, and looking at the latest and cutting edge research. So we really hope you enjoy the topic that we have this year on hip health. And on behalf of the McCaig Institute, I would really like to thank Dr. Donna Wood and the Wood family. And I hope that her aunt Mark Southern is here as well, who she often attends with Donna. That'd be fantastic. And enjoy our next Wood Forum. So with that, I'd like to pass it on so we can hear more about hip health, and I'll be listening intently myself. Thank you very much.
Thank you very much. You know, they're doing so many great things at the Wood Forum, especially at the McCaig Institute. So, you know, thank you for all the hard work that you're doing. You know, welcome all again. And, you know, we're talking about hip health today. And I want to thank you, especially the Wood Forum gives us this opportunity to talk about our different joints. I mean, the last time I was here, you know, I talked about my shoulder a little bit, but today we're going to talk about hips, and I'll tell you a little few stories about my hips in just a sec. How many people have hip health problems? I mean, that's probably what brought you here today. You know, these manifest in a variety of ways: walking up the stairs, bending down with your knee, you know, to tie your shoes, getting in and out of the car. These are all things we take for granted until you can't do any of them anymore because of your hip pain. For some, hip pain is a constant issue, and while others experience just sharp pains occasionally, you know, discomfort and stiffness from hip pain can significantly limit mobility and can sometimes be debilitating. I know from my own personal experience, you know, I was a little kid playing soccer, you know, just running down the field, but I had a collision with the guy, and his knee hit me just right in the hip. And it was actually, you know, I struggled. You know, I was in so much pain. I tried to stay on the soccer field. But, you know, as a kid, this is the first time I had to come off the field because I was in pain. And I just felt so bad about it. You know, that was really my first hip injury. But the one I remember the most actually didn't occur on a playing field. This is mid-season. Mid-football season, I move into a new apartment building. And unfortunately in Calgary, 4-story apartment buildings aren't required to have elevators. So I had to have myself, my friends, we moved into the top floor, the 4th floor. And I ended up scaling those stairs something like 40 different times in a single day. You know, went to sleep and then went to practice the following day. And my hip just wasn't firing right. And actually, you know, it feels like it heals. But actually at that point, I actually lose a lot of the flexibility that I used to enjoy in my hip, you know, unbelievably. And so I required a lot of yoga, you know, a lot of stretching, a lot of rolling to really get into a place. And actually, I'm very proud to say, as of today, I can cross my legs for the first time in over a decade. So I'm very proud of that. You know, I didn't have the opportunity to cross my legs for most of my life. And now I have that back. So, you know, it's only through the support of my medicals team, you know, my trainers, my doctors, that I was able to get back to this place. You know, it's not a place I've ever enjoyed really before, but now, you know, I still have a personal interest in hip health. I mean, it's so fundamental to what we do. And I know for me personally on the football field, yoga was something that I always turned to. But, you know, I think for everybody, you know, with different kinds of injuries, you need different kind of treatments. You have to approach them differently. And so that's why I very much look forward to our next presenter today. You know, let's talk a little bit about Dr. Emma Billington. You know, she's going to discuss hip fracture risk and prevention. Dr. Emma Billington is an associate medical director of the Dr. David Hanley Osteoporosis Clinic and a clinical assistant professor at the University of Calgary Cummings Medical School of Medicine. Originally from Vancouver, she completed her medical training and including a residency in internal medicine and a fellowship in endocrinology at the University of Calgary. She then completed an osteoporosis fellowship at the University of Auckland in New Zealand and has been practicing in Calgary since 2016. In addition to seeing patients, Dr. Billington is currently involved in several osteoporosis research studies, and her research aims to improve the delivery of care and education to people at risk of fractures, and to explore the unique nutritional and medical approaches that are able to prevent osteoporosis and fracture. Dr. Billington, over to you.
Oh, thank you very much. First technical gaffe of the day. I forgot to unmute myself, but hopefully everyone can hear now.
Everybody does that.
I'm looking forward to chatting with you about bone loss and hip fractures and some preventative tips. So with that, see if we can get the slide to advance. Perfect. So within the next 15 minutes, hopefully I can give you a little bit of an update on how and why hip fractures happen, and go over 5 healthy habits to help prevent fractures, hip and other bone fractures, and bonus points if you're still awake at the end of the 15 minutes. So a little bit here on hip anatomy. So the hip is a ball and socket joint. It's one of the largest joints in the body and a major weight-bearing joint. And because I'm a bone endocrinologist, I have a photo of an x-ray here showing the 2 bones that make up the hip, which are the femur, as well as the pelvis. And the part of the pelvis that opposes the hip joint is called the acetabulum. And then that would be the socket. And then the ball of the joint is something called the head of the femur. And so I'm going to be mentioning fractures here. And when I say fracture, I'm just talking about a broken bone. And if I'm talking about a hip fracture, then I'm referring to a fracture of the femur, which most often happens at either the neck of the femur, which is the right-hand red line on the image on the right. And then there's also something called an intertrochanteric fracture, which is a very common type of hip fracture, which is the other longer red line on the image. And if I mention a low trauma or fragility fracture, what I mean by that is just a bone that breaks as a result of a force or a trauma that wouldn't usually cause a bone to break. So a fall just from standing or ground level, maybe on your carpet or on the ice, that caused a broken bone would be considered a fragility or low trauma fracture. So hip fractures by the numbers, they constitute about 15% of all fractures, and about 30,000 Canadians will unfortunately fracture their hip each year, and about 3,000 of those are Albertans. About 1 in 6 women will have a hip fracture in their lifetime. And even though hip fractures and also osteoporosis are more common in women than men, after we reach age 50, about 1/4 of hip fractures actually occur in men. And about 95% of hip fractures happen because of a fall. They're almost always due to osteoporosis, but people can also have hip fractures due to traumatic injuries, such as a motor vehicle collision, or in Dr. Boyd's case, a traumatic sporting injury. So just something to think about there. I'll be focusing more on osteoporosis related hip fractures. So why do fractures happen? And this relates to both the hip bone as well as as well as other fractures. And to think about this, we have to consider both the strength of the bone and also external forces that are applied to the bone. And a fracture happens when the bone is subjected to an external force that's greater than the strength of the bone itself. And there's lots of different factors that determine our bone strength, including the thickness of the bone, as well as the quality of the bone and the architecture, so how all the components are actually built together. And then external forces can be things like a motor vehicle collision or a traumatic sporting injury, or just a ground level fall, say on carpet or the ice. So to put this in context, if someone has very strong bones and they are subjected to a small external force, then likely there's not going to be a fracture or a broken bone. On the other hand, if we have someone with either very weak bones or a large external force, like a motor vehicle collision, then we can get a fracture. And in some cases, the bones are weak and the force might not even be strong, and that can still result in a fracture. Or on the other hand, someone could have strong bones, but a very big external force, and that could cause a fracture. All right, so I mentioned weak bones. How do we get those? And I think probably most people are familiar with the term osteoporosis. So what exactly is that and who gets it? So the Latin translation would be porous bones. And where that came from is actually originally the way to look at the bones was on autopsy, to take a sample and look under the microscope. And it was seen that actually about 75% of our bone looks like a sponge. So it's something called trabecular, or the other word, fittingly speaking, is spongy bone. And so I've got two pictures up here, one on the left showing normal bone, which I think looks like a sponge. Hopefully you can see it too. And then on the right is a picture of osteoporotic bone, which looks like there's lots of sort of holes in the sponge and the connections aren't as thick. And so what osteoporosis is really the bone getting thinner and or weaker, which makes it more susceptible to fracture. And I've just got a little picture here of scaffolding, because I think of the bone and the connections and architecture within the bone as being quite like the scaffolding or the foundation of a building. And you can imagine if some of those pieces are taken out, or they're thinner or they're weaker, it's not going to stand up to forces as well. And that's the same with the bone. And that's what happens when we get osteoporosis. So I mentioned osteoporosis is both the thinning and or the weakening of the bones. So how and why do the bones thin? Well, unfortunately, it's all downhill after age 30, and bone loss is pretty much a universal part of aging. So we all hit our peak bone mass in our 20s to 30s on average, and men begin a bit higher than women. And then after about age 30, we start to lose bone on average up to 1 to 2% a year. And this continues up until around age 50, which is approximately the average age of menopause in women. And due to lower estrogen levels after menopause, women actually lose much more bone in that few years after they've gone through menopause. So they lose up to 3 to 5% a year, whereas men are still ticking along at about 1 to 2% a year. And at about age 60, things even out again for women, but they end up lower than men on average. And so that's why osteoporosis tends to be more common in women than men as we age. And so we can actually measure bone thickness and determine how much bone people are losing over time using something called a bone mineral density scan. And some people may have had one of those in the past. They're very common. And what it is a special type of X-ray that usually looks at the lower spine, the lumbar spine, as well as either one of the hips. And it gives us a sense of how thick the bone is. So it tells us the density or thickness, and that can be used in the clinic to help determine someone's individual risk of having a fracture, so a hip fracture or another fracture. However, what we're learning is that it's not just about the thickness of the bones, it's also about the quality of the bone material and how it's all put together in the architecture. And we're actually really lucky here at the McCaig Institute in the bone imaging lab to have something called an extreme CT machine, which is a state-of-the-art high resolution CAT scanner that you can actually put your arm or your leg into, and it can give us a readout of not only the bone density at the wrist and the ankle, but also the bone quality and the bone architecture. And this is being used in lots of research at the moment, but I wanted to highlight one study because it pertains specifically to hip health. And so this is a study led by Dr. Boyd at the Bone Imaging Lab. And what we're doing in this study is using the extreme CT, so that high resolution CAT scanner, and recruiting healthy individuals who've never had a hip fracture, taking pictures of their bones and comparing those to people who have just recently had a hip fracture. And the goal is to actually be able to use these imaging characteristics to identify people before they have hip fractures in the future. And so the study is still ongoing, but you can see on this slide on the left, this picture of a healthy individual's bone. And you can see it's really like the architecture looks really nice. It does kind of look like a sponge. And then on the right, you see an individual who's had a hip fracture, and there's lots of spaces or gaps there or voids. So they do look different. And so we'll be analyzing lots of people. And once that's done, stay tuned. One of Dr. Boyd's grad students is actually using some machine learning technologies to see if we can really proactively determine people's risk of hip fracture. All right, so it's really fun and cool to look at pictures of the bones and analyze those. But I do have to highlight that other factors are very important too, and in addition to just how thick the bones are and how they look. So one of those is age. As we get older, we do lose bone and bone becomes weaker. So as we get older, we're also more likely to have hip and other fractures. If we've already had a fracture, that does put us at risk for having another one. And then other risk factors, unfortunately, we can't choose our parents, but about 70 to 80% of our peak bone density, so as thick and strong as the bone's going to get in our 20s and 30s, 70 to 80% of that is determined by genetics. And then there's lifestyle factors, which I'm going to talk about on a few slides ahead, as well as some medical conditions and medications can make us more likely to fracture. So what can we do to prevent hip fractures? And the good thing about that is the things that we can do to prevent hip fractures can also help us prevent other fractures. So we can focus on maintaining strong bones, and ways we can do that are maintaining a healthy lifestyle. And for some people, I won't have a chance to talk about this today, but in some cases, medications can be helpful for this too. And then we can also do our best to limit external forces. And obviously that's one of those easier said than done things, but driving safely, being careful with high risk sporting activities, and doing what we can to avoid falls. So I'm going to start now with my 5 tips to prevent fractures. So tip number 1 is to eat a balanced diet. And this is a picture here of Canada's food guide that was released last year. And I've got it up here because it really mirrors what we see in observational studies, which are studies where they recruit people and find out what they eat and then look at them over time and see who fractures and who doesn't. And what we consistently see is that people who eat diets that are really rich in fruits and vegetables, that get enough protein, and overall eat more whole-based, home-prepared foods rather than processed foods, tend to have a lower rate of fractures and hip fractures in particular. What you might notice here is that, hey, there's not a lot of dairy on the plate. And well, I thought calcium and dairy were really important for preventing fractures. And that is a really good point. So Canada's food guide has amalgamated dairy in with the protein section of the plate. So it's not as much on the forefront when we look at the new recommendations. However, that doesn't mean that getting enough calcium isn't important for fracture prevention. And so I just wanted to highlight this. Our Canadian guidelines recommend that we get about 1,200 milligrams of calcium in our diet a day. What I will mention here is that our Canadian guidelines are very conservative, so they want to make sure that everyone's getting absolutely enough calcium. A lot of the research that exists suggests that maybe 700, 800 to 1,000 milligrams is probably okay for the average person. And if we were living in a different country, some places like the UK and Scandinavia recommend about 700 to 800 milligrams a day. So in my clinic, I'm usually happy if people are able to get 800 to 1,000 through their diet. And you can actually get about 300 to 400 through a balanced diet that doesn't include any dairy or any specific sort of trying to get calcium in. But if you do consume dairy, it's a great way to get that extra top up of calcium. But this image on the right on this slide is from the US Department of Agriculture and shows lots of non-dairy foods that are very rich in calcium. So for each of my tips, I've got a little quick action that you could take right away to sort of start using that tip. And for this one, I suggest maybe getting a recipe and trying making a meal with a calcium-rich food that you haven't tried before that's new to you, just to get it on your mind and get thinking about it. And people often ask me in clinic, okay, but what about calcium supplements? Should I take one? And what I will say is this could be its whole hour talk on its own. So I'm not going to get into that in detail. I'm happy to answer any questions about it though at the end. But in general, if you're getting enough calcium in your diet, there's not a lot of evidence for a benefit of taking a supplement. So diet is best in this regard. And then tip number 2, get enough vitamin D. So vitamin D helps our body absorb calcium. And we get it not only from our food, although food is not a great source of vitamin D, we can also get it from supplements, and our skin makes it in response to sunlight, UV light. And so if we were living, say, in Florida right now, closer to the equator, getting lots of sunlight outside year round, we might not need to take any vitamin D, although our research in Calgary specifically, as well as across Canada, shows that if nobody took vitamin D, about a third to half of us would have vitamin D levels that are low enough that they could be detrimental to our bone. So the general recommendation is to take a supplement, and anywhere between 400 to 2,000 seems to be safe and effective to getting us to the levels that we need. And in our Calgary vitamin D study, which I'm going to talk about on my next slide briefly, we found that actually 400 gets people to a pretty reasonable level. So for about 90 to 95% of the population, that should be just fine. Although your doctor might recommend a higher dose if you're at risk of deficiency or known to be deficient. So a quick action you could take today if you are not taking any vitamin D, especially going into the winter, is maybe consider starting a 400 international unit supplement, or if you're on a multivitamin, you might be getting that much already. So that's something you could check. And I'm just going to highlight a second research study ongoing at the McCaig Institute at the Bone Imaging Lab. And this is again run by Dr. Boyd, as well as Dr. David Hanley, who's a professor emeritus at the University of Calgary. And I was lucky enough to be involved in this study with them. And what we did, it's completed now, but we randomized over 300 people, all from the Calgary area, to get vitamin D, a daily dose of either 400, so that was the dose that I said is probably reasonable for the majority of people, or high doses of 4,000 or 10,000 international units a day. And they took this for 3 years, and we used this extreme CT technology to get nice images throughout that time of their wrist and their ankle. And what we actually found, which was a bit of a surprise, was that the people on the highest dose actually lost more bone than the people on the 400 international unit dose. So in general, more is not necessarily better, and 400 for the majority of people tends to be fine. And tip number 3, again, this is another easier said than done one, but kick unhealthy habits. So we know that people who smoke are 30 to 40% more likely to have a hip fracture. And we know that consuming more than 2 drinks a day is associated with a higher fracture risk. And so what is a drink? Well, this image on the left is not your standard drink. So your standard drink would be a typical glass or bottle of beer, 5 ounces of wine, or 1.5 ounces of spirits. So some people say, okay, I might not want to drink again at all, and I'll switch to water. Fine. However, if you want to continue to drink and maybe just reduce your portion size, there actually is research out there showing that if people drink out of tall, thin glasses, they feel like they're drinking more than drinking out of short, wide glasses. So take that as you will, but something to consider. Right. And I've got 2 more tips here. So tip number 4 is exercise. And we all know exercise is important for so many health benefits. And we know that for preventing osteoporosis and preventing falls, it is also important. The recommendation in Canada is about 150 minutes of moderate to vigorous, so 5 to 8 on a scale of 1 to 10 activity each week, and it should be weight bearing where possible. Jumping has really good data in terms of bone outcomes, but there's lots of other weight bearing activities. And while things like swimming and cycling aren't weight bearing, they have a lot of other excellent health benefits. So if that's something you do and enjoy, it's good to continue. Maybe just try to pepper in some weight bearing activity too. But then things start to get even more detailed with the recommendations. So our Osteoporosis Canada recommends daily posture and balance exercises, as well as resistance training 2 to 3 times a week. And putting that all together, it's a lot. And it's a lot to think about, well, what do I actually do? Ideally, people could work with a trainer and have a program that's tailored to them, but of course that's not always possible. And so a really good starting point that I recommend is going to the Osteoporosis Canada website, which is osteoporosis.ca. And they have an excellent booklet called Too Fit to Fracture. It has recommendations as well as pictures of some starting exercises, posture, balance, and resistance that you can try. So that's a great starting point that you could do today. And tip number 5 is, again, another easier said than done one, but don't fall. So mitigate your falling risk where you can. So maybe don't walk on any tight ropes in the sky. And then also, we know that exercise, specifically balance exercise and things like Tai Chi, are really good for reducing the risk of falls. So what you could do as a quick action today is maybe start a daily balance practice, just something as simple as standing on one leg at a time for 30 seconds while you're brushing your teeth or waiting for the kettle to boil. All right, I'm almost done, I promise. So in conclusion, my 5 tips to maintain bone health and prevent fractures: eat a balanced diet with calcium, get your vitamin D, kick your unhealthy habits, exercise, and don't fall. Thanks very much. Oh, and actually just want a really quick point here. If you want more information, our local website from the Dr. David Hanley Osteoporosis Center is a good resource, as well as osteoporosis.ca from Osteoporosis Canada. Thank you.
Hey, thank you so much, Dr. Billington. So much great information there. One important point I want to bring up: it's important not to give up your hip workout, folks. It's not a waste of time. Now, so for me, actually, you mentioned Tai Chi, Dr. Billington, and Tai Chi has been huge for me. And one thing I noticed, that I started doing Tai Chi in 2014. And when I went there, you know, I was surrounded by people that looked pretty old, but they did not look old when they moved. 90-year-old, 92-year-olds that were just moving normal. And when they're in the Tai Chi set, they're able to sort of get all the flexibility that you're looking for sort of in your day-to-day life. You can sort of make sure your body's getting those movements. And then when you go about your day-to-day life, you have more balance. You have more control of your body. And that just, as Dr. Billington was saying, just makes you that much more prepared if a weird situation happens. Amazing information. You know, I was blown away. 30,000 hip fractures a year. You know, so it's great that we're all here having this discussion today. I had a neighbor who had a hip fracture, and she was 87 years old. You know, her garden, you know, for a few months went bad, but, you know, she got the treatment she needed, and then she was right back out there. So, you know, no matter how old you are, hip treatments can get you back to where you were. Next, I'd like to welcome Dr. Liam Martin to share his research into the effectiveness of CBD for the management of arthritis pain. Dr. Liam Martin is a member of the Division of Rheumatology in the Department of Medicine and a professor at the Cummings School of Medicine at the University of Calgary. And he is a member of the McCaig Institute for Bone Health and Joint Health. He is very interested in the early diagnosis and management in patients with arthritis, and then the application of a patient-centered approach to care. He has been performing clinical trials in new therapies in arthritis for over 25 years. So I'd like to welcome Dr. Liam Martin to share his thoughts.
Thank you very much, John. I should own up to the fact that I'm not actually an investigator in CBD, but it has become a very interesting part of my practice, especially when patients ask more about CBD and cannabis in general at the clinic when it comes to managing their arthritis and the pain associated with the disease. So over the next 12 or 15 minutes, what I'm going to do is just talk about cannabis and CBD in relation to what it is, where it came from, what the internet says about cannabis and CBD, what studies are out there, whether or not you should use cannabis products, and then if you do decide to use CBD, how you might approach using these medications or supplements. So cannabis is a flowering plant. It's known as hemp, Mary Jane, bud, weed. And if you watch movies over the years, you'll hear many other different terms for it. It's a member of the Cannabaceae family of flowering plants. There are at least 170 different species in this family. And the ones that come up in discussions about cannabis usually center around Cannabis sativa, Cannabis indica, and Cannabis ruderalis. And Cannabis sativa is probably the one that's most frequently discussed in terms of cannabis and cannabis products. So cannabis plants can grow to be very tall. The sativa plant can grow to 4 meters in height, and it tends to be very spindly. And the part of the plant that's really important from the point of view of cannabis products is the flower of the plant. And it's the female sativa plant that's most important when it comes to isolating the products that we have available now that cannabis is legal in Canada. Where does it grow? Well, it grows in the wild in Central and South Asia. And this is a picture that I stole from Wikipedia. And it's from Islamabad in Pakistan. They obviously haven't got around yet to building the embassy for Afghanistan at this site because they're probably too busy growing weed. But it's available across those parts of the world in the wild. So cannabis sativa has been used in medicine for thousands of years. There are recorded references to it in Chinese medicine back in 4000 BC, in Indian medicine, meaning East Indian medicine in 1000 BC. And interestingly, it was brought to the West by an Irish physician. So you have an Irish physician talking about a product that was brought to the West by another Irish physician a few years ahead of me, although he's not that much older, or younger, I should say. He worked, William Shaughnessy was born in Limerick in Ireland, the city my wife is from. And she says there are still Shaughnessy's there who are involved in medicine. Although many of them are probably not directly related to the late William Shaughnessy. So he was a member of the British Army Medical Corps, and he worked in India in the mid-1800s. And he brought cannabis back to the West because he had seen how it was used in medicine in India and how effective it could be in certain individuals. As a recreational drug, or a recreational product, I should say, it's been legal in Canada since October 2018. And we were the second country after Uruguay to legalize cannabis. And we're also in the top 4 for the use of cannabis products and cannabis in general, along with Zambia, the US, and Nigeria. And cannabis can be grown, cannabis plants can be grown and made to produce certain products. So for example, we have colleagues at the University of Lethbridge with whom we were planning to do a study on cannabis or CBD in the management of pain and rheumatoid arthritis, who have been growing cannabis plants for many years through a license with the Canadian government. And you can grow these plants to have a heavy level of CBD produced, or to have THC, which is the part of cannabis that causes people to have psychoactive responses to it. But there are other chemicals present in all of these cannabis extracts that also have to be looked at when you're looking at products. And then in the States, it is legal to grow hemp, which has very little THC in it for the production of hemp fibers, which are used in many different areas. And also products of hemp can be used for skin products as well. The main feature of the cannabis that is grown for hemp is that it has to have a very, very, very small amount of THC or CBD in it. One interesting piece of knowledge that I generated through working with Dr. Jason McDougall, who was a member of our McCaig Institute until he moved off to Nova Scotia a number of years ago, was that our bodies have natural cannabinoids, and we have receptors for these cannabinoids in our body. So on the left of this, you can see the natural or endocannabinoids that we have and what their names are. I'm not going to try and pronounce them. And then you have the phytocannabinoids, which are the cannabinoids that are extracted from cannabis plants. So the discovery of the endocannabinoids is not that old. It's just over 30 years ago that people started to become interested in cannabis receptors in the body. And what we know is that they play a role in maintaining homeostasis or balance in the body functions. Exactly how the cannabis does this is not clearly understood. But we have two different types of receptors. We have CB1 and CB2, but there are other ones that are being discovered over time. And it's thought that these endocannabinoids play a role in some disease states, either positively or negatively. So there have been studies done looking at animal models where the animals have been infected with different organisms. And in some cases, the animals did well when they were treated with cannabinoids. And in other studies, they did poorly. So it depended on the organism that was infecting them. But again, these studies are in a very infant level, not infantile, but in their infancy, because we are very much in the early phases of studying cannabis and cannabis products in humans. The CB1 receptors are present in the brain, lungs, the vascular system, and the CB2 receptors are present in the spleen and bones and the immune system. So this is where the interest in CB and cannabinoids comes from the point of view of studying them in immune conditions like rheumatoid arthritis. If you look at how these products that we have from cannabis plants work, THC, the part of the cannabis plant that causes the psychoactive behavior, which causes people to get high, there's many of those receptors are present in the brain. So it's not surprising that when people smoke cannabis that they can have a high out of the product. You see, the CBD receptors are not as tightly bound to CBD as the THC ones are, but the CBD can play a role in reacting with pain receptors in the body and help to reduce pain. Now, this is just a graphic of where we look at the receptors. So CB2 receptors, which is what CBD will react with, are present on immune cells, and the CB1 receptors are present on neurons. But both products, the THC and the CBD, will interact with both neurons and immune cells. We're just not at the level yet of sophistication of knowing exactly how these products work in conjunction with each other. So lots of studies are ongoing that have not been published yet. So it's interesting that we're talking about hip joints, and Alf here has obviously he'll have hip joint problems as he ages, but he also has difficulty rolling his joints because he has osteoarthritis in his hands, which makes it difficult to function. So Alf is having troubles on at both ends. So what does the internet say about CBD treatments for arthritis on Google? Well, I did a search using the Google search engine and found 2,980,000 results in 0.44 seconds, which is much faster than the results of the voting in the US was counted. Maybe they should have asked Google to do it for them. But what does this mean? Well, for me, it meant that my connection to the internet through Shaw was good. It doesn't mean that this information is real. It doesn't mean that it's all been studied, because when you look for real studies, I mean, by that I mean studies where there have been different populations studied over time to see how effective these products are in treating arthritis or the pain associated with arthritis. There are very little data. And these studies, can you trust them? Well, generally speaking, if your studies are published in peer-reviewed journals, you can trust them. But when they're just anecdotal studies, anecdotes are not data. They're anecdotal. They're good for the patient who wrote the information into the internet through a web page or a blog. But for the general population, they don't really apply. There was one reference study which looked at osteoarthritis and the pain associated with it being attenuated by CBD. And that looked great. And especially when I saw that Dr. McDougall, my colleague who is now, as I mentioned, working in Nova Scotia, and this was published in a well-respected journal called Pain in 2017. But then when you actually look at the whole title of this talk, or of this study, I should say, the attenuation of early phase inflammation by cannabidiol prevents pain and nerve damage in rat osteoarthritis. So if you have any rats in your house, although there are not that many rats in Alberta, I understand, you could treat them if they have osteoarthritis in their hips with some CBD, and they won't limp around your house any longer. But it just shows you how you have to be careful what you read on the internet before you decide that you're going to use a product. This attenuation of pain and osteoarthritis, then when you put the whole thing together, reminds me of the ancestry.ca ad on the television, which says my grandfather was, and then at the end it goes British, and then you find out my grandfather was a soldier in the British Army, and he was presented with a medal by the British for bravery. So you have to look at the whole title of the talk, of the article. There has been a preliminary assessment of the efficacy, meaning how well it works, the tolerability and safety of cannabis-based medicine in the treatment of pain caused by rheumatoid arthritis. And this was published in a respected peer-reviewed journal in 2006. The journal is Rheumatology. But it was a very small study. There were 58 patients. It was very short term, of 5 weeks. And as any of you who may have rheumatoid arthritis or who treat rheumatoid arthritis will know, rheumatoid arthritis is a chronic disease. It's not a one-off, and it's there for a long period of time. Patients have symptoms for a long period of time. And what they used in this study was an oral spray of both THC and CBD. And there was a small statistical difference between the groups in favor of the cannabis product, reducing the amount of pain and how well patients felt. And what they suggested was that a larger study needed to be done to see if this initial pilot information was actually was true in the sense that it would hold up over a longer period of time. So there are no large randomized studies of cannabis products in arthritis. And there are many reasons for that. If you are a cannabis producer, you don't have to do studies to show that your product is useful, as long as you don't make any claims to its medical usefulness. Cannabis producers do not have to do studies. They just have to show that their product is safe. Companies use testimonials, anecdotal reports to support their products. Clinical studies are very expensive. You have to have investigators who are interested in doing the study. You have to have investigator staff who are willing to run the study with the investigator. There are medical legal issues that have to be addressed before studies can be done. There are ethics approvals that have to be achieved. And you have to have enough people in the study to show that the product that you're studying is going to help. And you also have to have a specific product. So the product has to be identifiable and has to be reproducible across a period of time by the company who are studying the medication or the product. So when a patient asks me in clinic, should they use CBD for managing their pain? Well, the first thing I like to tell patients is that I don't have good data to share with them on the effectiveness, the amount that they should take, the safety of the medication, or the duration of therapy that they need, or how long basically they should take the drug. As I mentioned, testimonials and anecdotes are not data. But we have colleagues who have a big interest in CBD products and who will be able to advise patients on whether or not they should try these products, or what products to try. What products have been shown to have been consistent in what they say is in their product. If you are going to take a CBD for your pain, what should you know? You should know what you expect. So I presume most patients would want to know if it will help the joint pain. They want to know if it has any adverse or bad effects. They want to know how long they should remain on it. They will need to find a brand they can trust. So again, referring back to the physicians who work at cannabis clinics, who have a background in working with many of the companies who produce these products, they can give them advice. It's important that the brand you choose has consistently produced a quality product. Again, reputation is important and purity is important. Manufacturing changes can affect the quality of the product. So if a company is making the product in one way for a period of time and then switches over to what looks like a more effective and less expensive way of making the product, they have to be able to show you as the consumer that the product is still as good as it was when they were making it the old way. And then the other thing you can do is you can look at patient comments online, or you can ask a friend if they've tried the product. And it's interesting, even when we prescribe medications such as biologic therapies, which are used in the treatment of patients with severe rheumatoid arthritis, we will often be told when we discuss with the patient, which of these products would you like to try? Have you read anything about them? They'll tell you about a friend or a friend of a friend or a colleague at work who has tried one product and they want to try that one. So that type of person-to-person contact is really important when people are trying to decide what kind of CBD product they would like to take. And then when someone is deciding to take a medication, in our world, we build up the dose. We know what dose we would like to start with. We know what manipulations we can make to the dose. And the same thing should apply when you're using CBD, for example, for the treatment of your joint pain. And in most instances, the doses are measured in milligrams, and it depends on the weight of the patient and on the severity of the pain. Oops, sorry. What you should also know is what are the adverse effects. With CBD, all the adverse effects tend to be minimal. You can have a dry mouth. Some people feel a bit dizzy and lightheaded when they take particularly the higher doses of it, and it can make some people feel drowsy. What you also have to be aware of is how much THC is in the product. Although CBD oil and the way it's produced, it can come in capsules or it can come in a dropper, there will always be a little bit of THC. You need to have as little THC in the product as possible, because the THC is the part that causes psychoactive activity. And then you should also know how long you want to take this product. So for example, when we're treating somebody with rheumatoid arthritis, we expect a medication that we use, like a disease modifying therapy, to work within 3 months. If that doesn't happen, then we move on. And I think the same thing with osteoarthritis. If somebody is going to use an anti-inflammatory medication to help manage their pain, we will ask them to take it for 2 to 4 weeks to see if it's effective. If it's not effective, again, we move on. So patients should apply the same rationale if they're going to use CBD. There's no point in taking something over and over again and expecting a better result if you're not getting any result after you've been on it for a period of time. It's a waste of money. All right, that's as much as I'm going to say. And we will be entertaining questions at the end, so feel free to ask any questions you want. Thank you for your attention.
Thank you, Dr. Martin. So much great information there. I think there's a lot of questions still, but with cannabis only being legalized more recently, I think, we're sort of at the point now where we're going to start seeing some science come out to actually see the efficacy of the effects of cannabis, CBD, and THC. So, folks, we're now at the halfway point. So I would like to invite you all to take a 3-minute break so you can stretch, grab some water. Remember, don't turn off your computer or the webinar. There will be a countdown on the screen indicating the start of the next presentation. So, folks, welcome back from the break. Next, I would like to welcome Dr. Raj Sharma to discuss his latest research on hip replacement surgery. Dr. Rajrishi Sharma is an orthopedic surgeon and a clinical assistant professor at the Cummings School of Medicine at the University of Calgary. 5 years ago, Dr. Sharma brought anterior hip replacement to Western Canada and continued to teach his approach to surgeons throughout Canada. This endeavor has led him to win a Surgical Innovation Award here in Calgary, an award for major clinical contribution as a junior surgeon. His research continues to focus on the outcomes of hip and knee arthroplasty, with a focus on the anterior approach to hip replacement and on the impact to the healthcare system. Dr. Rajrishi Sharma, over to you.
All right. Well, first of all, thank you to the McCaig Institute and the Wood Forum for inviting me to give a talk on an area that I'm very interested in. And I also like to congratulate both the McCaig Institute and Wood Forum to transition this to an online whereby we can reach a lot more individuals who are interested. I'll give a quick shout out on that note. Actually, I invited my parents and my family to join this as well. They hear me talking about this all the time over dinners, and they never really got to see any presentation I've given. So this is a great way to reach out to more people. So I'm going to jump into this here and feel free to post any questions and we can definitely get to it at the end. So what I'm going to be doing here is I'm going to talk about technology and medicine in general. Talk about hip replacements in general, and then jump into the anterior approach. Some of the research that I've done, it's ongoing, and then talk about another exciting area that I've been devoting my time into, which is digital navigation, and then we'll summarize it up again. So to jump into it, medicine practice today is virtually unrecognizable from the turn of the last century, and technology will continue to transform medicine. It's very exciting in that manner. But with new technology, it has a potential of improving quality, efficiency, and safety. But we have to be careful because it can be sensitive and can introduce new risks and dangers. But we always need to strive to use technology to help advance our techniques. So total hip replacement or arthroplasty. It's one of the most effective and safe orthopedic procedures, and it's just exponentially increasing the number of procedures that we perform because of the success of the hip replacement. And both Canada and US data show that. What is a hip replacement? So in general terms, we take an arthritic hip, we basically cut out the arthritic part and we replace it with a prosthesis. And it is the single most successful surgery of all disciplines in surgery to increase a patient's quality of life. And we've heard Jon mention that. So what am I talking about here? Basically, I'm talking about how we get to the hip joint, because regardless of how we get to the hip joint, hip replacement surgery is just a good operation. And so the majority of hip replacement surgery worldwide is performed through something called a posterior approach, where we go through the back and to approach the hip joint to replace it. The other common way of performing it, and it's most common in Canada, is the anterolateral approach, whereby we, again, approach the hip joint. And in both of these approaches, we have to take off muscles and tendons in order to get into the hip joint to expose it. And once we can expose it, we can replace it. But with some of the approaches, dislocation of a hip joint is one of our most feared complications and situations that can happen. It can happen up to 5% in hip replacements, especially highest with the posterior approach. There are studies showing that if reattachment of some of those tendons and muscles that we have taken off are reattached, that we can reduce the risk of dislocating. But regardless, dislocation is still the highest with the posterior approach. When we look at the other approach, which is the anterior lateral approach, it reduces the risk of dislocating, but you can have a persistent limp, which can continue on even up to 3 months. And that's because of some of the muscles that we take off and again, have to reattach at the end. So it's a balance between dislocating and limping that we always have to play. And because of the fear of dislocating, here's what we teach patients beforehand. So for the first 3 months, don't lay on the operative side, use a raised toilet seat, use a chair cushion, and walking aids for up to 3 months and sometimes longer if necessary. And then for life, don't bend past 90 degrees, cross your legs or pillow between the legs when you're sleeping. And all these precautions are just to try to avoid the hip from dislocating. But our patients are changing. As time is going on and with the success of hip replacements, patients are getting younger. And while they're getting younger, their demands are changing. They're asking us for shorter recovery, quicker return to work, fewer post-surgical limitations, and more durability. And us as surgeons need to figure out how we can meet these demands. So what is the anterior hip replacements? The anterior approach is essentially another way of getting to the hip joint through the front, which is an internervous and intermuscular plane. What that means is we're able to get to that hip joint without disrupting a lot of those muscles and tendons. It's not a new approach. In fact, it's been described in the 1940s, but this technique is only starting to gain popularity now, and that's because of standardized instruments and teaching programs. So what is it? So we go through the front between two of these muscles called the tensor fascia and the rectus muscle, which gives us good exposure of the hip joint. And what it effectively allows us to do, it allows us to maintain all the dynamic stabilizers of that hip joint. Now, what that means for patients, it means an increased stability to the hip joint, a shorter inpatient stay in hospital, reduced risk or the lowest risk of dislocating at somewhere between 0.2 and 0.4% in the literature, faster functional recovery, no restrictions after surgery, and less pain. So there's a picture of one of my patients who's 6 weeks after having her hip replacement performed. But the benefits also go beyond the patient themselves. So from the anesthesia point of view, during the case, they have full access to the patients because they're lying on their back. And so if something were to go wrong, they have full access to patients to provide the necessary care. From the surgeon's perspective, we can use X-ray during the case, and I'll come back to this a little bit later, which allows immediate feedback. So I know exactly where all the implants are. I know exactly what has happened during the procedure, and I can make adjustments if necessary. From the nursing and the rehab perspective, they're extremely excited when they have a patient who has a hip replacement through an anterior approach because they have less pain. Patients are more independent and able to move around a lot easier after surgery. And the hospital administrators also are quite excited about it because there's less bed congestion. In other words, we're able to have patients be discharged home safely, quicker. So this is the same slide that I showed you beforehand with the restrictions after surgery, but with the anterior approach, it's a lot different. In other words, all these restrictions which we have normally asked patients to do, with the anterior approach, essentially there are none. And so patients are able to be up and walking and are more comfortable. And so after surgery, as long as your surgeon is comfortable with it, there's no restrictions post-op. And here's a patient of mine. So, and by the way, all the videos that you see on this are from patients of mine who have agreed to allow me to show these videos. So here's a patient who's had her right hip performed in just less than 20 hours. So it's just less than a day, and she's up and walking around already on it and feeling quite comfortable. So the anterior hip replacement, there are some restrictions on it. So in my practice, 95 to 98% of any patient who presents to me with hip arthritis requiring a replacement would be a candidate for it. But there are some limitations behind it. And some of those limitations include morbid obesity, congenital deformities, if it's a revision operation or we have to do the surgery again, or if there's fractures, specifically periprosthetic fractures, fractures around a previous hip replacement. So why is it only starting to gain popularity now? It's because it is technically a lot more difficult in the operating room. So it does take a bit longer to perform the procedure. It is physically a lot more demanding for the surgeon and surgical team. There is a large learning curve associated with learning the procedure. It is a bit unfamiliar if you have a surgeon who hasn't done it before and the team hasn't done it before. It's just a different way of looking at the hip joint. There are new instrumentation which need to be taught and used to, and it can be disorienting at times. So here's one of those instruments. This is an orthopedic table. It's used for the anterior approach. It's not necessary, you don't have to use it for the anterior approach, but certainly makes the surgery a lot easier. So here's a patient of mine. She's 3 days out from having, she's home. And this is the same patient who's 17 days post-op on her canoe. Less than 6 weeks post-op, she's going for a hike. 12 weeks post-op cross-country skiing, and she's so excited by it. She sends images of herself to our office, just how excited that she is. And here's another patient of mine. She asked me to show this video because she was so excited that in less than 6 weeks she's able to wear her high heels. So I told her I would definitely show this video whenever I can on my presentations. And so research is an area of interest of mine and something that I always enjoy performing. And so some of the research that I'll talk to you about is some of the safety and the cost effectiveness of the anterior hip replacement. So I'll start off with a retrospective matched cohort study. And essentially what this is we took patients who underwent primary uncomplicated hip replacements through the anterior, posterior, and lateral approaches. We excluded those patients who had both hips done at the same time, or hip resurfacings, or infections, or revisions. And basically, we took these patients and we looked at approximately 115 anterior hip replacement and matched them to 230 posterior approach and 230 lateral approach patients. We matched using age, gender, number of medical comorbidities, and BMI. So what did we find? So this was essentially the conclusion. There was no statistical significant difference at 30 days for readmissions of patients and no significant medical events. So we showed that it's actually safe. In fact, when we looked at it closer, there were significantly fewer mechanical complications. So what this includes is dislocating. There is shorter length of stay in hospital. Patients were able to go home directly more often rather than having to go to a rehab hospital because they were more comfortable and be able to pass our physiotherapy requirements. Fewer blood transfusions. And the most interesting part was the patients were consuming less narcotics in hospital and they were reporting less pain in comparison to the other approaches. The average surgical time was longer with the anterior approach in comparison to the other two approaches. So we were quite excited about this and our preliminary data, and we began to increase the ability to perform this on various diagnoses. So we took this to the next step. We looked at patients who had hip fractures and said, well, can we apply this to hip fractures? And as per current care pathway, the average length of stay with a patient who has a hip fracture may not be Dr. Boyd, but it was between 9 and 14 days in hospital. And so we took the patients and we fixed a cohort of them who were able to get up and mobilize and are relatively a bit younger and performed it through the anterior approach. And we were excited to see that we're able to reduce the length of stay in hospital to approximately 2 days and 12 hours and 30 minutes to be exact. So this was remarkable. And then we took it to the next level. Here's a patient of mine who has both of his hips are extremely arthritic. And this is how he has to get into his truck because of how arthritic those hips are, in a very uncomfortable way. So what we did, we took these patients who in general had a length of stay, if you imagine 2 different surgeries being performed, they would have to be performed at 2 different time points. And so the minimal time between surgeries would be about 3 months. So a total time to recover about 6 months. So here's hips, and again, as we initially saw the X-ray with the hip being a ball in a socket, there was really no space left between this ball and the socket of both of these hips. So we took him to surgery, and I performed bilateral anterior hip replacements on him. So at the same setting, was able to replace both of these hips. And what was remarkable, so he's now 4 weeks after surgery. He likes to joke around a bit, so he started trying to make this video, and he said, "Oh, forget it, I don't need these canes," and started walking. So it's remarkable, at 4 weeks after having both of his hips replaced, has completely changed his quality of life. Now, when we look at our actual data that we had collected afterwards, it's even more remarkable, because patients were essentially comfortable. They were consuming minimal narcotics, even after having both their hips performed, and they were being discharged home quicker. So these patients were being discharged home the following day, versus if they were having 2 separate procedures performed, and the average length of stay is about 3 days on a standard hip replacements. We're looking at a difference between being discharged home the following day versus 6 days in hospital in total. So, of course, it makes sense that if patients are in hospital less, that we must be saving money to the healthcare system. So patients are being more happier. They're being able to perform a lot more and faster functional recovery. And then we want to look at the perspective of the healthcare system. In summary, I'm just jump to the basic conclusion. What we're able to show is that even when we subdivided all of the costs, and we used a micro-costing technique whereby patients were, every dollars that the healthcare system had to spend while they were in hospital were calculated, we averaged saved approximately just under $2,000 per patient that had the anterior hip in comparison to the lateral and posterior approaches. Now, there's a second way of calculating that if you just look at length of stay and using an average number, but essentially, if we use the micro-costing as the better approach, that we save just under $2,000 per patient per day. And what does that, per patient per procedure? Now, what does that mean? If you look at it from a broader scale, if we just do 200 patients, we've saved just about $370,000. So with the immense success of the anterior hip replacement, I then took it to the next level and said, well, if patients are more comfortable and they're able to be up and mobilizing quicker, why can't we do this at the same day? So in other words, allow patients to go home the same day after having their procedure performed, which is extremely relevant with the situation we're currently in with the pandemic, and patients don't want to be in hospital very long, which is understandable. And so for the last 3 years, I've been performing same-day total hip replacements, and it's amazing to see how well patients do. In fact, some of the happiest patients are those patients who don't have to stay in hospital and go home the same day. So here's an example of that. So this is a patient who's 4 hours after having the replacement, and I apologize, this was a video, but it doesn't seem to be playing unless we can have the AV individuals play the video. Oh, there it is. Thank you. So this is only 4 hours after having his left hip replaced, and he's essentially walking past the physio, and at 6 hours, he's good to go home. So as excited as we were, I began performing anterior hip replacements at the Peter Lougheed Center in 2015, and we were the first in Western Canada, and only the 3rd site in Canada to perform it. And since then, there's been a slow and careful uptake. Excited to say that all 4 sites in Calgary right now are performing it with 3 orthopedic tables. We have approximately 8 surgeons in Calgary performing the anterior hip replacement, and we're likely the single largest city currently performing anterior hip replacements based on the number of surgeons performing it in a single city. With the data that we collected, we were able to publish our cost-saving, our micro-costing analysis in HIP International. And if we looked at, again, the amount of money that we saved over the course of 5 years, we've saved well over $1 million already. And this is just exponentially increasing the more we perform the anterior hip replacements. And I've had the privilege of teaching surgeons across Canada and especially within Alberta as well. So I'm going to take this to a different thought process. It's something called digital navigation. And this is another exciting area of technology that I've been using for approximately a year and a half, close to 2 years now, and exploring how this can help us even further with the anterior hip replacement. So with the anterior hip replacement, like I mentioned, you can use X-ray during the procedure in order to identify where these prostheses are being placed. And X-ray allows for immediate feedback so that all alterations can be made if necessary. With using the X-ray, we can use something called digital navigation software, which is essentially software that allows us to template digitally what we should be expecting during surgery. And then during the procedure, allow us to make necessary changes. It's non-invasive. It allows us to have better implant selection positioning and helps us achieve leg length and something called offset, which is where the hip is being placed more accurately. So how does it help me? It's basically, I like to call it as data-driven surgical decision-making. And again, just before surgery, I'm able to take the information in the X-rays and use the software to digitally template beforehand. And during the procedure, again, you can use a predictive trial analysis, whereby, in other words, a fancy way of saying that you can trial a hip and figure out exactly what's right for that patient, depending on what the deformity was beforehand. And it really helps us understand better how the hip is behaving. And so I'll just show that in a very difficult case of a 77-year-old female who previously had her hip replaced 15 years ago, had a difficult postoperative course, and so really did not want to undergo another replacement on her other side and tried to avoid it as much as possible. In fact, she had a dislocation after having the right hip performed. It was in a brace for about 3 months. And eventually did well on the right side, but just did not want to undergo her left hip. But eventually got to a point where she just didn't have a choice anymore. She just could not bear to live the way she was. And if we look at these X-rays, it's pretty easy to tell. You get the right hip, the image on the left side where the prosthesis is placed. That would be that patient's right hip versus the left side. You can tell there, if you look at the ball in the socket, not only is there absolutely no space, but the ball doesn't even look like a ball anymore. It's basically flattened out completely. And so she's basically eroded away part of that ball or the femoral head just because of how the bone-on-bone arthritis just kept rubbing against each other. So this becomes a very difficult case in order to, technically as a surgeon, if I just draw a simple line at the bottom, we can see that this patient not only has a bad hip, but it's about 15 millimeters short, so a centimeter and a half short of that left leg because of the erosion of that hip joint. And so as a surgeon, I will always try to see if I can improve that and try to get it closer if possible. Sometimes it's not. So we take this digital navigation software and we be able to overlay implants beforehand to see what am I trying to achieve during surgery. During surgery, I'm able to use this digital navigation software to help place components and make sure that I have the right degrees of where I'm trying to aim for that implant to be placed for each patient. And sometimes it may be slightly different, but it allows me to make those adjustments. Once I'm able to do that, I can then trial and see if what I've achieved is what this patient hip will allow, and if I can make alterations on that. And if so, if I'm able to achieve that extra bit of leg length that I started off performing. And by using that software, sorry, let's go back a bit here. By using that software, I was able to achieve equal leg length for this patient and a stable hip joint. So it is remarkable, and it's a new way to really think about hip replacements, and it's quite exciting as well. And so exciting that this patient here of mine was jumping for joy and how happy he was with the hip joint. It's just about 6 weeks. Not that I recommend doing this, but he was extremely excited about it. So in summary, total hip replacement is one of the most effective and safe orthopedics procedures, regardless of how it's performed or regardless of which approach, to be honest. But the anterior approach is a way to help improve rapid recovery after surgery. Hip replacement surgery is #1 surgery known to mankind to improve patients' quality of life. Despite the immense success of hip replacement, we continue to try to make it better, and digital navigation is just one area where we're currently looking into. Thanks.
Beautiful. Thank you, Dr. Sharma. Remarkable developments, 20 hours to recovery. I've never, you're doing God's work right now. So thank you so much. I wanted to say that, I used to do the twist and show, and then I went to see Dr. Sharma, and after that hip replacement, I was fine. So thank you so much, Dr. Sharma. So up next, we have Shannon Falsetti to provide us with an overview of two current models of care in Alberta, the Catch a Break and the Fracture Liaison programs. Shannon Falsetti is a nurse clinician supporting the Alberta Health Services Bone and Joint Health Strategic Clinical Network. What's the adjective for that? And their Fragility and Stability program, which focuses on bone health and prevention and care for fragility fractures. Shannon provides clinical knowledge and expertise to guide the care provided to hip and fracture patients across the province. Shannon started Alberta's first Fracture Liaison service and is now one of the provincial co-leads for the continued improvement of osteoporosis care in Alberta. Shannon and her Fracture Liaison service colleagues were the 2018 recipients of the Alberta Health Services President's Excellency Award for Research and Innovation for their work in secondary fracture prevention. Over to you, Shannon.
Well, thank you for that warm welcome, and thank you for the McCaig for having me here today. I'm going to go ahead and jump right into this presentation. So earlier, we heard from Dr. Billington on how to prevent bone loss and fractures. But what happens when we do have fractures? Today, I'm going to talk about two Alberta programs, Catch a Break and the Fracture Liaison Service, that address our current osteoporosis care gap. How common are osteoporotic fragility fractures? Well, here are some fast facts from Osteoporosis Canada. Over 2 million Canadians are affected by osteoporosis. 1 in 3 women and 1 in 5 men will break a bone during their lifetime. Over 80% of all fractures are in persons over the age of 50 and are due to osteoporosis. 1 in 3 people who fracture their hip will refracture within a year. And unfortunately, there's a high mortality rate associated with hip fractures. We can see from this picture, osteoporotic fragility fractures are more common than heart attack, stroke, and breast cancer combined. Surely, a disease that affects so many would be well recognized and treated. Unfortunately, that is not the case. Around 80% of patients who have sustained a fragility fracture will neither be assessed nor treated. An 80% post-fracture osteoporosis care gap is in stark contrast to the excellent rates of care offered to patients after other serious events like heart attack and stroke. Fragility fractures are not benign. We can see the outcomes following a hip fracture are grim. Less than half will ever recover their full level of independence after breaking their hip. Close to 1 in 5 will need to be transferred to a long-term care. Sadly, 23% of women and 36% of men will die within that first year. Interestingly, most hip fracture patients already had a prior fracture. So you could call those warning fractures, and that people were warning us that they were at risk for more devastating fractures. Addressing fragility fractures is becoming increasingly important as our population ages. By 2046, 1 in 5 Albertans will be a senior. And as we saw in a previous slide, osteoporosis is one of the most common chronic diseases. Such we cannot afford to ignore it. You're likely asking yourself, why are we not recognizing and treating osteoporosis if it's so common and can have devastating effects? Great question. Some may characterize osteoporosis fracture care as the Bermuda Triangle. Although fracture patients are seen by many healthcare professionals, none of them are in a position to take responsibility for the underlying osteoporosis. The orthopedic surgeon's job is to fix the fracture, and this is done well. No one suspects osteoporosis, so they're not referred to a specialist. And patients are typically too busy running back and forth to the hospital and the CAS clinics that they're too busy to see their family doctor. And in fact, their family doctor may not even be aware that they had a fracture. The treatment gap is the lack of integration within the medical system, such there is no clear concept of who is responsible for the fracture patient. Thus, they are lost. The Bone and Joint and Strategic Clinical Network is closing care gaps by addressing the lack of integration within the healthcare system, connecting all the pieces of the puzzle so we understand the bigger picture in respect to comprehensive post-fracture care. The Fragility and Stability Program focuses on 4 main areas of fracture care. 2 programs that I'm going to talk about today that address the current osteoporosis care gap are the Catch a Break and the Fracture Liaison Service. Catch a Break, or CAB, is a province-wide program initiated in 2014 by the Bone and Joint SCN and done in partnership with HealthLink to identify patients who've had a recent fragility fracture of the wrist, arm, spine, rib, and pelvis for the assessment and treatment of osteoporosis. CAB is a telephone-based service that facilitates communication between individuals and their family doctor about osteoporosis and treatment options to improve their bone health. Patients who are seen in emergency departments or in CAS clinics will be mailed a package introducing them to the CAB program and letting them know that they will be contacted by HealthLink for further bone health follow-up. Patients are also given information on osteoporosis, risk factors, diet, exercise, and calcium and vitamin D. HealthLink contacts patients by phone within a few weeks of their fracture. If a person's fracture is suspected to be fragility related, patients are advised to complete follow-up with their family doctor if they have not already done so. If patients have not seen their family doctor, follow-up calls are done at 3 and 12 months to help remind patients of the importance of seeing their doctor to discuss their bone health, and they also encourage them to follow through on their doctor's recommendations. In 2019, CAB screened over 12,000 people after a fracture. 92% of those screened have visited their family doctor as a result of participating in the CAB program. This has resulted in an improved diagnosis of osteoporosis. Increases in identifying osteoporosis improves osteoporosis treatment. When looking at treatment numbers in Alberta before and after the initiation of the CAB program, with CAB, Alberta saw an increase in osteoporosis medication use from 5 to 43%. We also saw an increased use in calcium and vitamin D. By catching people early with their warning fractures and assessing, diagnosing, and promoting osteoporosis management, we can cut the risk of experiencing more fractures, hoping to prevent people from ever experiencing a hip fracture. But hip fractures do happen, and our second osteoporosis program, the Fracture Liaison Service, seeks out these patients for osteoporosis treatment and falls management. The FLS is specific to hip fracture patients, as these are the highest risk patients in that their risk for another fracture is imminent. 1 in 3 people who fracture their hip will re-fracture within a year. The FLS is a dedicated team of RNs and doctors who identify patients who've been admitted to hospital with a high-risk hip fracture for the assessment and treatment of osteoporosis. The FLS RN meets with patients and family shortly after they are admitted to hospital, and the nurse completes a thorough assessment and bone health history. This information is reviewed with the FLS physician, and an individualized bone health care plan is developed for each patient. The patient and family are important members of the plan development, and this plan of care can encompass many things, including osteoporosis medications, fall prevention strategies, and any additional referrals that may be appropriate to the person's care. FLS nurses provide robust education to all hip fracture patients, tailored to their bone health needs. The FLS provides support to patients for up to a year after their hip fracture. Telephone follow-up is done every 3 months as needed for the subsequent year. This is where the nurse checks on how people are taking their osteoporosis medications, and if they're having any issues, the nurse and the patient troubleshoot these problems together. The nurse also asks about the person's mobility, falls, and if they're experiencing any problems in their recovery. Referrals are arranged as required to address any risks that were identified in the follow-up calls. Communication is a big part of FLS. We want a strong link between the hospital and the community. Patients get letters sent home with any important information about their bone health, and family doctors are kept updated with any relevant information throughout the year on their patient's bone health. And at a year's end, a summary is provided to the family doctor to help with the ongoing management of the person's bone health. There are currently 10 FLSs across Alberta in our major hip fracture hospitals. The first FLS was started by myself in 2015 at the Misericordia, and our most recent addition was the Chinook Regional Hospital in Lethbridge in 2019. Since its inception in 2015, FLS has assessed and provided bone health teaching to over 11,000 people and enrolled over 7,600 patients into the FLS. Now, not everyone who breaks their hip is enrolled. For example, if a person broke their hip from a major trauma event, like a car accident, they are provided information about bone health, but they're not enrolled as their mechanism for fracture is a little different than osteoporosis. But for those with high risk fragility hip fractures, with FLS involvement, we got osteoporosis treatment numbers up to 52% that subsequent year. Now, we can't put everyone on osteoporosis medications. Some medicines are contraindicated for certain persons. Some people will refuse treatment, and other persons are at a palliative care level. But a 38% increase in treatment is impressive. And of all those enrolled into FLS, 98% are receiving appropriate management for their bone health. Oh, my phone went to sleep. Sorry. FLS has made a number of referrals to improve people's access to appropriate care to address any other underlying issues that may be contributing to their fall and fracture risk. Hip fractures are the most devastating fracture, and what is worse than breaking a hip? Breaking another hip. Thus, preventing future fractures is of utmost importance in this high-risk group, and Alberta is making a difference in reducing subsequent fracture risk. Again, by assessing and diagnosing osteoporosis, starting osteoporosis medications, and promoting other bone health practices and fall prevention strategies, we can significantly reduce the risk of future fractures for Albertans. And presumably, if we prevent future debilitating fractures, people will have better outcomes. An important thing I want to emphasize about CAB and FLS is they don't just move patients through care. Remember that Bermuda Triangle patient who was lost? CAB and FLS are meant to find those patients. These programs are the integrated models where health professionals are seeking people out to provide them with information and link them to appropriate care to promote their bone health. CAB and FLS are making a difference in the quality of life for thousands of Albertans by preventing debilitating fractures, by helping people make informed decisions about their bone health, and supporting people in being active members in their care. That concludes my presentation today. Thank you for all listening. For more information, you can check out the Bone and Joint SCN webpage as listed. I do also want to give a quick thank you to Osteoporosis Canada as they let me steal a lot of their slides for my presentation today, so thank you.
Beautiful. Thank you, Shannon, for that wonderful presentation. And thank you to all the presenters today. We had a great amount of just learning opportunities. I know I personally have learned so much. I want to open it up to questions now. We've received quite a few questions over the course of the day, so we'll get to those. But I'd like to encourage everyone to join the discussion, ask some questions. They're happy to field any general questions you may have. But again, we aren't giving out the specific medical advice. So try to limit those in your questions. And we want to just run through this. We have about 20 minutes left. So we'll try to get to all the questions. And the first question we're going to start with, sort of a pair of questions, just sort of out to the group. Is one, range of motion fully restored after a hip surgery? As well, is there any downside to delaying a hip surgery?
So I guess I'll take this question. So range of motion after surgery. So it depends on what you say normal. Is it normal in comparison to what they had when they were 20 years old, or is it normal later on? So hip replacement surgery will improve range of motion. but to what extent is quite difficult to tell from patient to patient. So the reason for that is more than just the joint itself. So around the joints, we have our ligaments, our tendons that I had spoken about, and some of those can get contracted. You can imagine that if someone has a hip arthritis for years and years and years, these ligaments and tendons get contracted more chronically over that course of time. So just by replacing the joint, you still do have those contracted muscles and tendons that have to be stretched slowly over time. And so it's a slow and continual progress to increase that range of motion. And you do improve it, but to what extent is difficult to tell from patient to patient. John, I'm sorry, the second half of that question,
so what's the downside to delaying a hip surgery?
Oh, right. Okay.
If there are
any. Right. Yeah. So the downside, there's a few of them. There is a downside that just like the one difficult case that I had shown, the longer you delay it, there is a risk of losing bone. And us as orthopedic surgeons, we use that bone to recreate the joint. So the less bone that there is, it can become technically more difficult. So that's from the surgical standpoint. Now, from the patient standpoint, the delaying surgery and having chronic pain of that hip joint can lead to other issues in terms of decreased quality of life, depression, and there's many other aspects to it as well from the patient as a whole when we look at them.
Beautiful. Anybody else? Very well said, Dr. Sharma. So the next question has to do with sort of some of the chemicals and drugs you can take. Thoughts about use on zoleronic acid, calcium supplements, and vitamin D. What are some of the things that people can take to better sort of cope with the symptoms of hip issues?
I can certainly speak a little bit to that in the sense of osteoporosis. So I think, as I mentioned, important to get enough calcium in your diet for bone health and to maintain or help maintain bone as much as possible. We know that calcium in the diet has less of an effect on blood levels of calcium, so it's sort of more smoothly absorbs into the blood. It doesn't peak the levels, and there's a concern that peaking the levels up with taking a supplement that's not embedded in food may have potentially harmful effects over time. Again, that's a bit of a contentious issue, but if you can get calcium in your diet and you can get enough of it in your diet, then there's not a lot of additional benefit from taking a supplement. So I think that's kind of one thing. And again, that's for the majority of people. Some people, you might need to talk to your doctor individually and see if they would recommend an extra supplement for you. But in general, diet is best there. Vitamin D, really what we know is anywhere from 400 to 2,000 units a day seems to be reasonable for the average person. There are some people out there that might need more. And again, that's sort of an individual talk to your doctor sort of thing. And if you've been known to be vitamin D deficient in the past or have major risk factors for that, then you might need more. Calcium and vitamin D together don't necessarily lower the risk of breaking bones. There's some debate about that, but a lot of the biggest studies, and when they put together studies that have been done and analyze them all together in a big group, they've found that, depending on how they're analyzed, they probably don't reduce the risk substantially of fractures. If they do, it's probably reduced on about the amount of 10 to 15%. Whereas segueing into the question about zoledronic acid or medications to lower the risk of, well, I think it was just asked about hip health in general, but I'll talk to it from a sort of osteoporosis fracture standpoint. When we think about medications, lowering the risk of fracture, depending on the type of fracture and the type of medication, most of them lower the risk by about 40 to 50%. When we think about spine fractures, some of them, like zoledronic acid, lower the risk by about 70%, whereas medications aren't as good at preventing hip fractures. So usually they only lower the risk by about 25 to 40%. And just to back up a little bit, because people had asked about zoledronic acid, but what actually is that? It sounds pretty crazy, a type of acid, but it's actually just the way that the medication is formulated. It's acidic, and its other name is aclasta. That was the trade name. It's now been around for about almost 15-ish years, and it's now generic. But basically what it is it's a type of medication that stops the cells that dig up the bone from doing so and helps to harden the bone over time. And so it's one of our mainstay treatments for osteoporosis and preventing fractures. Some people might be familiar with weekly pills that can be used for osteoporosis, and it's a cousin of those that's actually given once a year through the IV. So I'm going on a little segue here from the question that was asked, but this is very much so medications can reduce the risk of fracture, and that's been shown in a number of trials, but they might not be appropriate for everyone. They're most appropriate for the highest risk people. So if that's you, if you've had a fracture or think you might be high risk, then that's something to absolutely talk to your doctor about, and potentially go through the different options.
Awesome. Thank you, Emma. And the next question, we're going to weave this in. Sort of, if you're drinking alcohol or you're smoking cannabis, can have those have any negative effects on your sort of prognosis or the any let's say issues with other drugs that you might be taking to deal with osteoporosis and hip-related injury?
I suppose if you're drinking alcohol and smoking cannabis, you run the risk of falling down, and you better find out what your bone mineral density is before you participate in both activities. But from patients that we see at clinic, oftentimes they will ask us about alcohol and whether or not they can take the alcohol in association with the drugs we use to treat rheumatoid arthritis. The advice we give them is that you do everything in moderation. So if someone is drinking their brains out, that's not going to help them anyway. So they may ignore their joint pain when they're drunk, but it doesn't help. So moderation is important, and moderation is important if you're going to be using cannabis products too.
Anybody else? Beautiful. I think you summed it up nicely. I have a few questions about sort of the length of the wait for hip replacement surgeries. Maybe you could talk about why we have we have a person saying that they've waited for 2 years for replacement, and another person saying that they've been waiting a long time as well. Maybe we could talk a little bit about sort of the expected wait time and why that is the case.
So, I mean, this is a difficult question. We're in a difficult situation. It's probably not easily answered here on this forum. It's difficult. If we had unlimited resources, we wouldn't have a wait list. So, at the end of the day, we're trying our best to get through as much as we can with the resources that we're given. We have fantastic group of surgeons here that are working hard to do as much as we possibly can. Limitations come from the resources given, and at the end of the day, we're in a difficult time right now. We're in the middle of a pandemic. We don't know if tomorrow we're going to be stopping surgery again. So, at the end of the day, we're all working hard. We respect, we understand, and we feel for each one of our patients who come in and tell us how long they've waited. We're trying our best, and quite honestly, that's the best answer that I can give at this point.
Well said, Dr. Sharma. Now, the next question, we're going to talk about a little bit, maybe this is back to you, Raj, a little bit about labral repair. So if you have a detached labrum, would that affect future hip arthritis, or maybe require a hip replacement in the future?
Yeah, this is really a clinical question that you should definitely ask once you have a consultation, because the trouble is it's not an easy direct statement. It's not A causes B. There's a whole bunch of other factors that can be involved. Sometimes the answer is yes, if it relates to a pre-arthritic joint, or the answer could be no, if it's trauma related. So It really depends on the cause, and really once you understand what the cause is and what the imaging looks like, and you can better answer that question on a case-to-case basis.
And there are quite a few sort of direct medical questions very similar to that, and as Dr. Raj Sharma made note of, we can't really be answering those kinds of questions in this forum. So here's something a little bit more general. Is there a link between bone health and muscle tightness? Do very tight muscles around the hip area affect the overall health of the hip?
So I'll try to answer this as well. I think we've had some great talks talking about bone health in general, and I think the key behind it is, as we heard, is with the top 5 items to improve bone health, exercise and weight bearing. So tight muscles around hip joint don't necessarily change the outcome of the hip, but certainly exercising, stretching, and just like John, you said, the yoga, tai chi, any of those type of things to help, continually to make and stretch that hip joint obviously does help.
Beautiful. And
John, if I could just add a comment there. One of my good colleagues, Dr. Tish Doyle-Baker from kinesiology at the University of Calgary, showed us a slide a number of years ago at our annual retreat where she had pictures of an MRI scan, a transverse cut from the thighs of a 70-year-old triathlete and a 74-year-old non-exercising male. And the difference between, and they had a 40-year-old as well, the difference between the 40-year-old and the 70-year-old triathlete was that there was some more fibrous tissue in the muscle of the 70-year-old. But when they showed the 74-year-old's thigh, it was fat for about 2/3 of the volume of the thigh, and the muscle had deteriorated significantly. So I think what that adds to is the comment that Emma has made about exercise is really important for maintaining balance and strength and supporting the bones that are underneath the muscles. So anyone who, as you get older, obviously cardiovascular exercise is important, but resistance exercise to retain muscle bulk and strength as much as you possibly can and to help with balance are really important.
Beautiful, beautiful. Now, this is about the anterior surgical approach. One question, is it available across Alberta? Like, would people down in Lethbridge have access to it? And maybe you could talk about the difference between your approach, Raj, and sort of what the other approach is.
Yeah, so you just have to contact the local clinics to find out if it's available in your area. We're working hard to increase the number of procedures being performed, but that increases slowly over time, and we've made great progress so far. In terms of the difference between the approaches, I hope I was able to cover that in the talk. It's essentially just a different way of getting to the hip joint.
Mm. Yeah, that's what I was thinking. So, is there a your post-surgery, is it possible to have an infection from the surgery years after the surgery?
Yeah, infection is always a possible complication. So we looked at our Alberta data and all of Alberta, and it matches that of everywhere else, less than 1% risk of infection. That can happen. Highest risk of infection after any surgical procedure, regardless of its hip, its knee, whatever it is, within the first 2 years is the highest risk of infection. After that, the risk of infection does reduce, but it's never at zero. There's always a chance of having infection years and years afterwards.
Okay,
and it's not necessarily from the surgery itself, I should just comment upon. The more years you're away from the actual procedure, there's other causes that can seed the joint that can cause infections.
Mm. And it seems like a lot of questions are coming in your way. So you get your hip surgery, after it's done, how long is sort of the life of that implant good for?
Yeah, so a really good question. So In about the year 2000, some of the technology changed whereby we were using a different polyethylene, which is a plastic liner inside the joint. That has completely revolutionized the length that the replacements last. So currently, our data that we have is approximately 25 to 30 years. About 70 to 75% of the joints are still lasting. So we just don't have data beyond that at this point. So it's lasting for a long time. I think right now, when a patient asks, I think 25 years is kind of a good ballpark figure. But again, the data still out because the technology is lasting longer and longer.
That's beautiful. When I get my hip replacement, I'll be happy to walk on that for 20 years. This is a question about mothers that have children. Do they have an increased risk of fracture? Is there some correlation there?
I can probably take this one. So yeah, good question. And we do know that at the time of pregnancy as well as lactation, there's lots of calcium mobilized out of the bones because that's needed for the fetus or for the breastfeeding baby. So people actually do have a reduction in bone density and perhaps bone quality during that time. That usually improves over the years after weaning, after lactation is done and pregnancy is done. And it's not something that we're usually measuring on a regular basis because even though bone density scans have a really low level of radiation, it's still not something that we want to expose a pregnant woman to. So we're not usually doing scans in pregnancy. But we do know that typically, yes, there is bone loss. Yes, it usually gets better. I haven't seen any data in older women to suggest that previous pregnancies have a strong impact on fracture risk. Of course, thinking about a child's risk after, if their mother has had a fracture, then that is a risk factor. So not necessarily because of the pregnancy, but because of genetic factors that make us more likely to break a bone if one of our parents has.
Beautiful. Now, maybe a follow-on question. You know, if you fracture one hip, does that sort of predispose you to fracture another hip?
Yeah, that's a good question. What we do know is that if you've had a fracture, your risk of having another one, any fracture, not just hip, is higher, and it's specifically higher in that year to 2 years after the first one. And then it remains even maybe 1.5 to 2 times higher than the general population for the rest of your life. So yes, if you have had one hip fracture, you would be more likely to have another one than someone who'd never had a hip fracture. But whether one hip fracture predisposes to another hip fracture specifically rather than fractures at other sites, I'm not aware, and I don't know that there's any good literature answering that question out there.
Okay. And then maybe the last question, you know, in terms of your athletic life, you're a younger person requiring, you know, potentially requiring a hip replacement surgery. Is this something that they should do when they're young, or wait until older? This is sort of the other side of the question asked earlier.
So I think the right time to do a replacement surgery is when you failed all non-operative treatment. When you're basically at the end of the line and there's no other choice and the quality of life is suffering enough. I think that's the right indication for it, regardless of age. I think, but it's important not to jump into surgery without having to go through the process of the non-operative treatments, which are important as well. Because you got to remember, surgery, it still has complications. You know, as good as a procedure can be, you know, there's always a risk of something happening after surgery or during surgery. So understanding those risks, again, surgery is always the final treatment option. And so to making sure you go through all those treatment options beforehand is important.
Beautiful. And with that, folks, we're going to shut it down here. First of all, I'd like to thank all of our presenters. We had Dr. Emma Billington, Dr. Leah Martin, Dr. Raj Sharma, and Shannon Falsetti. All wonderful presentations, and we learned so much today. So special thank you. A special thank you to Dr. Donna Wood, a close friend, and her family, and the Wood Joint Research Fund for their ongoing support that makes this all possible. If you'd like to learn more about how you can support this and other cutting-edge research that takes place at the McCaig Institute for Bone and Joint Health, please contact the Institute directly at mccaig@ucalgary.ca. And lastly, you'll receive an online survey in the next few days about the event. Please fill it out, and we very much appreciate your support. And most importantly, during this time, we're all sitting more, we're all like, sort of locked down in the house. It's important to take care of your health. And like the presenters talked to you about today, yoga, staying mobile, staying moving, those are all very important things, and all things we can very easily do in the confines of our own homes. So thank you all very much for tuning in, and we'll see you at the next Wood Forum. All the best.